I think the panel process was preceded by some wonderful comments from luminaries, from Director Botticelli, the Attorney General Holder, Governor Shumlin, David Mineta, and Nora Volkow. I think it's important for us to recognize that they helped set the stage, and I want to thank all of you for participating in this summit that draws together colleagues from federal, state, and local levels to share and leverage your experiences in dealing with the current heroin and prescription drug emergencies in the United States. I'm privileged to moderate the first panel of the day, which will discuss holistic public health, community-oriented approaches to prevention, intervention, and treatment of these interdependent and intertwined epidemics. It's my pleasure to introduce our panelists, and I'm going to introduce them all at the same time, and then I'll sit down and let them each come up and make their comments. Our first speaker is Nancy Hale, who is currently with Operation Unite. She serves as a project director with AmeriCorps and Unite's Service Corps. They have a grant. Their program employs some 44 full-time members in 11 counties in southern and eastern Kentucky. She brings to her current work her extensive experience in public education, where she served for 34 years as a dedicated teacher, administrator, and counselor. Nancy will be speaking about Operation Unite's three-pronged comprehensive approach to combat heroin, prescription drug, and other substance use disorders. The three-pronged approach is reflected in the UNITE acronym, which stands for Unlawful Narcotics Investigations, Treatment, and Education. Our second speaker is Dr. Michelle Lofwall, who is currently an associate professor in the Department of Psychiatry and Behavioral Health at the University of Kentucky. She also serves as a faculty member in the Center on Drug and Alcohol Research at the University of Kentucky School of Medicine. Dr. Lofwall conducts clinical research in the area of drug abuse, maintains an active opioid addiction treatment clinic, and teaches medical students, something that we've heard we need to be doing, residents and other allied health professionals about substance use disorders. Her research has been funded by the National Institute on Drug Abuse and is aimed at improving treatment of addiction. Today, Dr. Lofwall will share an overview with us of Kentucky's progress, as well as challenges in opioid abuse and addiction, prevention, intervention, and medication-assisted treatment. Our third panelist is Dr. Ed Bernstein, who is a professor and vice chair for academic affairs in the Department of Emergency Medicine at the Boston University School of Medicine, and is also a professor of community health sciences at Boston University School of Public Health. He is currently serving a 6-year term as a member of the Massachusetts Public Health Council. Dr. Bernstein will be speaking with us today about overdose prevention at the Boston Medical Center's Emergency Department. BMC's overdose prevention efforts includes the distribution of nasal naloxone kits, which serves as one example of practice-driving policy and scientific research. In this context, we know that there are 3 different naloxone opioid overdose prevention formulations, 2 of which have been in use for some time in clinical and community settings: the FDA-approved injectable naloxone, administered via needle, syringe, or through an IV, and the off-label use of this medicine as a nasal spray. The addition of the recently approved naloxone auto-injector highlights the sometimes competing parameters of access, cost, ease of application, and safety and efficacy that often confound medically necessary treatments, especially interventions that are needed to address medical emergencies. It is now my pleasure to turn the forum over to our panelists, and time permitting, we will have a moderated Q&A after the presentations.
This is a little bit different than speaking in front of a PTA organization, which I've had plenty of experience in the 34 years I was in education. Just to clarify the introduction that Dr. Clark gave, I am a part-time employee. I am a volunteer with Operation Unite. So I'd ask for you, I checked the seats before I came up here. They do not have seat belts, but I'd like for you to imagine putting on a seat belt right now, because I've been given about 7 to 10 minutes to cover what we've been trying to do in a small eastern Kentucky community to fight the substance abuse problems and to save lives. As a community member and as an educator in southeastern Kentucky, I am part of what's called the Rockcastle Unite Coalition. Throughout the 5th Congressional District, we have coalitions made up of community volunteers who are banding together to fight the substance abuse problem. It came about as a result for us in Rockcastle County. Now, to make sure I'm getting this right, top right, okay. This is the 5th Congressional District, the counties that are in color. We are represented here in Washington, D.C. by a wonderful congressman. I started to say young man, but he would probably enjoy that. Congressman Hal Rogers, who about 10 years ago realized that his congressional district was being devastated by drug abuse. And so instead, kind of like the governor of Vermont, he set out to do something, and he formed this organization called Operation Unite. We have a 3-pronged attack: law enforcement, treatment, and education, and I'm part of the E in Unite. Rockcastle County is one of the counties in green there. We're a small rural county. For a long time, we were very pleased with the fact that we were that Mayberry community. And then about 15 years ago, we began realizing, particularly in the schools, that we were dealing with a new problem besides the lack of education and the social and other issues. We were seeing more and more of our students coming in. Their parents had been arrested. Their parents had died of an overdose. We grew sick and tired of going to funerals, but we did not know what to do. Absolutely did not know what to do. We were well-educated people, but we had never faced a problem like this before. Rockcastle County is a small county. We have about 16,000 people. I was sitting next to the gentleman from Maryland, and I thought, you have no idea what it's like to live in a county that has 16,000 people. We have 1 high school, 1 middle school, 3 elementary schools, 1 hospital, 67 churches. So you can tell, you know, we're that picture of the 5th Congressional District. Extremely high poverty rate. We have a lot of unemployment in our county. We have 1 factory that's getting ready to leave us and move to Arkansas in September, so we're struggling to provide economic resources. But the thing that I think has made a difference in Rockcastle County as far as the substance abuse problem is that Interstate 75 goes right through the center of our county. We have a straight shot to Detroit, to Atlanta, to Florida, Cincinnati for the drugs, for the pipelines, and it's made a difference in the lives of our community. But as I said, we grew sick and tired of dealing with the deaths, the overdose deaths. We did not know what to do. And then for my family, it hit home personally. My husband was the principal at the high school. I was a counselor. And we realized that our son, 10 years ago, fighting an addiction, 1 person that we thought it would never happen to, 1 family that we thought it would never happen to. And suddenly, what do we do? I'm proud to say that he now has 6 years of sobriety, is in long-term recovery, but he's one that we did not lose. We lost too many others. And so for us, we began to see that education was going to be the key. I don't know, I wish I had known what I've heard this morning 15 years ago. We realized the hard way that we could never stop the problem by arrest alone. I've heard every person so far this morning say that. We knew that we could never fill up the jails enough to stop the problem. We knew that we needed treatment and education. We needed both of those to get people to understand what the dangers are, what the dangers of substance abuse are, what the harm is, the devastation that it causes to themselves and the people around them. And so out of that knowledge was born these coalitions made up of volunteers. As I said, we are the E in Unite, and the thing that we have in our little coalition in Rockcastle County is community buy-in. The first thing that we realized that we had to do within the education system, within our community, was to get people to talk about the problem, to realize that there was a problem, because we also realized that if we don't raise awareness of the problem, there's no financial support until knowledge of a problem exists. So we decided to build our coalition around the school. We had a captive audience there. And so our coalition is built around the education program. We have Unite clubs all throughout the 5th Congressional District, but in Rockcastle County, we have an anti-drug club in all of our schools. 4th through 12th grade. This year we had 763 students. Now what's so important about this is we are teaching them. We have a curriculum for substance abuse awareness. They take that information back home. They take that information to church. They take that information to their Little League team. We are helping them establish a foundation. We're educating them now as to the dangers and what happens to them. Dr. Volkoff doesn't realize it, but 2 years ago, 3 of my students and I went to the National Drug Summit in Atlanta and met with her. 3 students whose lives have been totally devastated by the loss of a mother, grandmother, father, and first cousin to overdose deaths. Every word that she said, they took back to Rockcastle County. At Rockcastle County High School, if a student says, Dr. Volkoff says it does this to your brain, people listen. You know, they have never met her or anything, but those 3 students made me realize what we can do through education, through educating these students. They don't just keep it in their backpack. They take it wherever they go. And so we believe that education holds the key. One of the ways we do that is with our Unite clubs. If we educate these young people, I believe that we can break the cycle. To do that, it does take money, but you're going to pay for it one way or another. We believe so strongly in education that we established a scholarship program within our county. This year we gave 3 $500 scholarships to help 3 students begin college. Last year, Operation Unite unveiled a scholarship program, I Am Unite Scholarship. It's for students within the 5th Congressional District. It is a $1,500 need-based and merit-based scholarship program. This year, we gave 23 students a $1,500 scholarship to help them get into college. We now have 42 freshmen and sophomores from the 5th Congressional District who are in college, but more importantly is several of them have gone to their colleges and have started a Unite program, an anti-drug program. So the message is spreading totally. One of the things that they have to do is write an essay as part of the application process. These are just 3 quotes from those scholarship essays. Every essay is the same, has the same subject. From first breath and first day of my life, I have been exposed to the drug world. An 18-year-old girl who was homeless, had been homeless since she was 12 in southeastern Kentucky because of substance abuse. Being a family member of someone fighting drug addiction, I know how important it is to have a group of people stand behind you with their support. That's what they receive through the Unite clubs. I have lost family members to prescription drug abuse, and I have seen the horrors that drug abuse can cause. It's not fair for a 17-year-old to have seen all of that. So we believe that through these scholarships that we're helping these students. We want them to come back to southeastern Kentucky. We want them to come back and make our community a better place, but at the same time, we want them to take what they know there. Now, some of the things that we do to raise awareness in Rockcastle County. We have a monthly radio program. We have a small radio station, WRVK 1460 on your AM dial, but we're also on the World Wide Web. Every month, the first Wednesday of the month, we have a 30-minute radio program. We bring in legislators, we bring in people in recovery, we bring in law enforcement treatment, just to help the community become aware. Out of the 16,000 people in our county, we average on the first Wednesday night of each month about 6,000 listeners tuning in to WRVK. So we feel like that this is a great opportunity for us to raise awareness. We also sponsor a football game. Yes, Kentucky, we love our basketball, definitely, but in Rockcastle County, we love our football. And so we, 8 years ago, began sponsoring the Unite Bowl football game. It's not just a game, it is an event. For 6 weeks leading up to this game in Rockcastle County and one other county that's playing us in the 5th Congressional District, We have programs, activities. We saturate the TV, the radio stations, using all sorts of media with all kinds of information and things about substance abuse awareness. We have many speakers that we bring in into the schools and everything. But one of the big events that we do, we try to help the kids see that there are so many things they can become involved in other than drugs. But we have a Wipe Out Drugs Challenge, and we collect toilet paper that we donate to treatment facilities. We found out, Tennessee and Kentucky, when they play, always have the blood drive, and everything. Well, 4th and 5th graders can't donate blood, so we had to come up with another way of getting them involved. Talked to some treatment facilities, and they said, look, one of the most expensive things that we have is providing paper products in our facilities. So that's how we came up with the Wipe Out Drugs Challenge. We've collected over 53,000 rolls in the last 8 years, and yes, we have counted every one of them because we have a traveling TP trophy that goes to the county that collects the most. It's a fun thing, it really is, but when our high school students deliver that toilet paper to the treatment facilities, and they talk to those men and women who are struggling with addiction, and they talk to those men and women who are in recovery, excuse me, that's when we see that education is important. They come back changed young people, and that's our goal. Okay, let me get myself under control here. 2 years ago, Operation Unite wrote an AmeriCorps grant, and we now have 44 members serving in 11 counties and 42 schools in southeastern Kentucky. The main focus of our grant, of course, is math education because we have to collect all of that data for the federal government so they'll know we're using the money wisely. But we also teach health and nutrition, and we teach a substance abuse awareness program. We have a 12-week curriculum. These are some of our students who began making some posters for us to use because this year, along with our Unite Service Corps program, and just to share a little bit with you about the impact, these are some of the statistics. This is working with 4th and 5th graders in southeastern Kentucky. 2,176 students were tutored in math, but the big thing is they showed a 32.65% increase in their math scores. That's what if they feel secure academically, that's going to help them in a lot of other ways. We now have 42 elementary Unite clubs for 4th and 5th graders with over 4,000 students actively involved in those clubs. We've educated over 4,500 students, 4th and 5th graders, in substance abuse awareness. But the thing that I get excited about when I go into these schools and visit the schools is that 2,169 parents and grandparents came back into the schools as volunteers for their children. A lot of these parents, the school doesn't have a real good taste in their mouth anymore. It was not a good place for them to be. But they're back in there, and while they're there volunteering, we're teaching them. We're giving them information about substance abuse. We're showing them how they can be part of the solution. And those parents logged over 17,000 volunteer hours in that 2-year time period. We have now facilitated, I'll give you some new data on this. We have just unveiled with Operation Unite a mobile prevention classroom. And we are traveling throughout the 5th Congressional District. We unveiled it in our county, in Rockcastle County, in December. We now have 2,982 7th and 10th graders who have gone through the 2-day program in the mobile prevention class. We've been in 27 schools, and so we are excited about what this is going to open up for us this year. We're working with the University of Kentucky and collecting the data and everything with that. But it's a daily battle. And so we have to tell each other constantly, this is the quote that our coalition and our high school uses. Harry Potter went to Professor Dumbledore and he said, basically, I give up. We can never defeat this evil. And Professor Dumbledore said, Harry, it is important to fight and fight again and keep fighting For only then can evil be kept at bay, though never quite eradicated. That's what we're trying to do through Operation Unite. Director Botticelli, I appreciate so much everything that you do and all of us. It's been exciting for me to hear that we have partners in Maryland and in Vermont, and especially knowing the partners that we have within Kentucky through education. We believe education is the key. Thank you.
Well, it's really an honor and a pleasure to be here, so thank you so much for the invitation. Let's see. So the toilet paper, while funny, I think also just makes me really angry and sad because that's the state of substance abuse funding, right? So are we bringing toilet paper to our loved ones who are in the hospital for other reasons? No. So just a little background. So in Kentucky, we're the highest rate of acute hepatitis C infection in the United States. We're the third highest opioid overdose death rate in the U.S., 2 times the nation's average rate. Our most recent data is from 2012, and we are seeing also an increase in heroin-related overdose deaths, 550%. And with regards to our prescription opioid overdoses, we're leveling off. We're not really decreasing or increasing. And notably, alprazolam is present in 41% of our opioid overdose deaths, and that's not inconsistent with the rest of the country, too. And I think we need to start talking more about the benzodiazepines. Because if we can make some headroads there, we might be able to also make some headroads with the opioid overdoses. But also with regards to the prescription opioids, I want to say that there's been a lot of attention given to the REMS. The REMS are all for the long-acting opioids, and what we see in eastern Kentucky is where there hasn't been quite the influx of heroin quite yet, but we expect it's coming because it's in North Kentucky, it's in Central Kentucky, it's in Western Kentucky. They've switched instead from the OxyContin long-acting to all the immediate release products that are quite available through generics, and they're very inexpensive. So the Perk 30s, the Roxys, that's really the same thing that's easily injected, and that's what people have simply switched to. So I think when we think about education, we need education on the immediate release as well because they're also equally as dangerous. We have 2 publicly funded opioid treatment programs in the United States, or in the United States, no, sorry, in Kentucky. The one in Lexington has a 1.5 to 2 year waiting list, which is has not changed in the last 6 years. That's for methadone. If you're looking for buprenorphine from that opioid treatment program, it's more like 6 to 8 months, but we know that that's still not adequate. We have been a state that has greatly expanded Medicaid, so we're really excited about that, and Medicaid is now paying for the physician visits for outpatient treatment that involves buprenorphine. So we're hoping that that is really going to help with our waiting lists and get people more into treatment. We have prescription drug disposal sites, 173 locations in our 110 counties. We've collected over 45,000 pounds since the program started in 2011. And we just last year passed a Good Samaritan laws for naloxone overdose prevention. So we're really excited about this and think that it has great potential, especially in our rural areas where it can be quite difficult for EMS to arrive even in a short period of time. But we haven't really seen the full-scale implementation of those quite yet, but we're quite excited about it, and our law enforcement is also quite excited about it too. I think one of the unique things that we've done that I've been very lucky to be a part of and wanted to share here is Governor Beshear is our governor in Kentucky, and he formed the CASPR Advisory Council. That's our state prescription monitoring program that's electronic. And on this council, he was sure to kind of put in everybody that might be involved. So it's the Board of Medical Licensure, the Board of Pharmacy, there's physicians that are psychiatrists like myself, so there's pain physicians, we have law enforcement, we have a representative from the Attorney General, we have police, and then there's more, so it would probably take up more than the slide. But anyways, we all come together in a single room, and we talk about worrisome opioid prescribing and the deaths and what everybody's worried about. We hash out potential ideas, and some ideas, you might think are really good, but then there's some unintended consequence that it's going to have, and having everybody together in the room is really helpful to make answers immediately without providing an answer that then has to be undone. So one thing that we've done is we've proactively screened for worrisome prescribing practices within our electronic monitoring system. So this way, if you do have a prescriber that is really having an insane amount of prescribing, prescribing something every 5 minutes, every day of the week that looks like they're never taking any time off or going on vacation. We don't have to wait for the DEA to come in or for people to die and have an investigation. We can pull those potential worrisome prescribers, have an independent look at who they are, make sure there's no mistakes in the system, because people do enter information into our CASPER system, and we can have errors. And then if it looks like this is a legitimate concern, it's then sent to the Kentucky Board of Medical Licensure for further investigation. And so that has been helpful. We've also passed House Bill 1 or 217 that gave increased authority to our Kentucky Board of Medical Licensure to actually state what are the standards of care for prescribing opioids for chronic non-malignant pain. And within this, there's now a requirement for checking of the state prescription monitoring programs before you prescribe and every 3 months afterwards. And there's recommendations for urine drug testing. So while that was implemented, we then had an unintended consequence of doctors or providers firing their patients immediately upon seeing a worrisome result, either on urine or on PMP. And so then this group, we came together and we developed education about how to interpret and respond therapeutically. So we are really working, when we're doing that, also on decreasing stigmatization of addiction. And we try and do this at all levels, because we see it at all levels: courts, insurers, prior authorization forms that pages and pages long have questions that seem totally inappropriate, like I'll be asked if my patient lives in a toxic environment before I'll get authorization for Suboxone or buprenorphine product. I'll have to have a special requirement. I'll have to fill out another one if I want to change the dosage form from 8 milligrams to 12 or from 8 to 2. I don't have to do that if I'm prescribing Prozac for my patient and changing the pill size. We do have an increased access to medication-assisted treatment. We have 437 waiver doctors. We have increase in prescriptions, but this really still isn't enough. We have a limited number of providers that take insurance. We're hoping that this is going to change, since Medicaid now actually provides payment for the physician visits. But our publicly funded treatment is limited even when we have priority populations. So if we have a pregnant opiate-dependent woman who's on methadone, she can get access to that treatment, but then that treatment ends at 8 weeks postpartum, which we think is very unfortunate, because that's when the crying curve starts for the infant that's coming home. So we really want to see reasonable reimbursement in PA forms, because these can't be a punishment to providers if we're trying to increase access. Like, it's really hard for me to do education and say, come do this, but you're going to need to hire another staff member to handle your prior authorizations and the insurances. So these are all of the free online programs that we have developed. Lots of this is through our CASPER's Governor Advisory Program. One thing that we do know is that education can work. This is just a site that shows one published study that shows that you can improve knowledge and it can be retained even 3 months afterwards, and that physicians will report positive changes in their prescribing patterns, and they will report poor behaviors too. So it's not the case that doctors will just say what you want to hear. And one of the best things to do is have your invitations come from the Office of Drug Control Policy in your state or your Kentucky Board of Medical Licensure, because you can pack a room without having to even pay them. So it's a great partnership. And I just want to conclude with saying that I just wanted to give a shout out to Van Ingram. He's our executive director for our Office of Drug Policy, and he's really been a huge support and has helped find the funding when we've needed it to even videotape our on-site educational things, so that they're then available for free online and free CME credit as well.
The clicker goes. Okay. I want to make sure I know which direction to go in. I wish I had a Google map where we could start off with the world and then go to the nation, the federal system, the national system, the state, down to the city, the community, and then what I have to talk to you about is something very granular, down even deeper, one hospital, one emergency department, and what was accomplished over a long period of time with collaboration. So that's basically the topic that I'd like to share with you. I'd also like to point out that as an emergency physician, we like drama and immediate results. So I think that's, in some way, that's led me to have some faith in naloxone. and Narcan, because we do see, as Dr. Volkov pointed out, people coming right to life, this reanimation. But I think we need to reanimate the whole society that we, in order to change this problem around our attitude towards addiction, to see behind the addiction to the people that are there, the human suffering, the fact that it affects individuals, families, communities, and that we're all in this together. My taxi cab driver today was from Afghanistan. He was talking about the impact of opioids in his country. And I think, we're part of one world, and we're so connected. In terms of a little history, I think I'd like to just take you through these events. In 2006, the City of Boston Public Health Commission basically established a pilot program that allowed for intranasal naloxone prevention programs, education, and distribution by trained non-medical and pre-hospital EMS personnel under a standing order by the EMS director. And then the City of Boston took on the legal responsibility to assume all liability for these workers in their ability to reach out and train the community in the use of naloxone and the risks of overdose. In 2007, our state took the Boston model to scale and as a statewide program, and we established an office of medical director who, under his standing orders, the naloxone was people were trained in use of naloxone and education, and then the state provided the medication and the education materials as well as small grants to communities. In 2009, our emergency department had an opportunity to partner with a community organization called the South End. That's the community we operate on. That's where our hospital is. Healthy Boston Coalition Initiative. And that was the first time that we had a chance to bring this program to the community and to build this partnership. And we were able to do this because we had a model in our emergency department that was actually supported by SAMHSA CSAT in 1994 called Project Assert. And this is when we brought people from the community with community professional attitudes and outlook and concern for people with addictions into our emergency department as health promotion advocates and licensed alcohol drug counselors. And this team goes room to room and consults with our physicians and also provides motivation and navigation for our patients to get to primary care, drug treatment, and other community resources. So this has been a tremendous boom. What's really interesting, for us in the emergency department, because we can't do this alone. And what's really new now is that in order to take a grant or a pilot project to scale, you really need institutional support. And our hospital has adopted a policy that no patient who's at risk for opioid overdose should leave our emergency department with the opportunity to have naloxone and education. So I'm sort of proud of this development. And I think it came about because of the good work of Project Assert and the community folks, but also our state has had some good experience with naloxone. And over the years since 2006, almost 25,000 individuals were trained and given naloxone, and of those, 2,800 or more had a reversal. So that's pretty substantial. And then a study was conducted in which those communities that had high penetration of naloxone in training and education had lowered mortality rates. This is our policy. It's been approved by the Medical Executive Committee. It enables standing orders to be issued out of the emergency department so that the pharmacy will send down to the emergency department after receiving this order naloxone that can be given to, a kit that can be given to the patients with both an educational leaflet and also the drug itself. It's under a standing order by Dr. Wally, who's our state director, but also one of our medical staff members. It builds on the existing program of Project Assert, but at the same time, it opens up the opportunity for physicians to write prescriptions to our pharmacy, and then after hours, when these programs are not available, for physicians to actually send this standing order form to the pharmacy. And this is the standing order form. And how did this come about? I think it came about because Project Assert had been building bridges to the community, and between building a bridge from the patients to the treatment system and from the community back to our hospital. And the Public Health Commissioner or director came to our president and asked for help in the opioid overdose epidemic in Boston. And our president basically came to the table and said that this is what we want to do, called on her leadership to do it. And so over a year's time, a policy was created, and the medical executive approved it. This is, we have ongoing training for our staff. We have over 120 people working in the emergency department, so it's a continuous process, and we have a residency training program in emergency medicine, and it's part of our safety net hospital. So this is what it looks like, the naloxone, nasal naloxone kit. The reason why we chose naloxone, The nasal form of it is acceptable. There's no needle sticks to worry about. It's easily administered and low cost. It's about $45 for a kit of 2 nasal naloxones. It isn't FDA approval has not been approved for nasal, as far as I know, but physicians, especially the physician director, can use off-label in our state, and I think that's been over the years, that's been the policy. So since January 2013, over a 15-month period, this is how many people we see in our emergency department with heroin or opioid-related visits. Of those, a third of them, almost a third, had opiate overdoses. And Project ASSERT was able to distribute 340 naloxone rescue kits and educate these patients during this period. I think that's quite an accomplishment because several years before, the numbers were much lower in the 50s. And I think because of the president's commitment to this policy in the hospital, taking this stand, we've been able to boost this up. But their hours are only from 9 in the morning to 11 at night, so we still have the night time to cover. We called some patients up on the phone to see what happened to the naloxone and what happened to them, because there is some public myth that if you give people a golden parachute, they're going to fall to their death. And so are they using more heroin or opiates? Are they overdosing more frequently? Are they not calling 911? Are they doing all these bad things because we tried to rescue them? In my mind, it's like saying, why did we build trauma centers? Because people are going to go out and shoot each other, and they're going to get into car crashes because we have a trauma center to rescue them. But what we noticed in calling the folks is that we've had increase in 911 calls and people staying with the victims and no untoward effects compared to people that got education alone. Am I cut off? Oh, sorry. Okay, sorry, everybody. Just last point, that we surveyed our residents and faculty to see how with their knowledge of this policy, with their attitudes towards it. And as you can see, the majority are now contacting Project ASSERT to get their support and doing this education. But in terms of actual distribution of naloxone and prescription writing, we're in the beginning phase, and people are beginning to do this. And when we asked about the barriers, we were pleased to learn that none of them had a disagreement on moral grounds or professional grounds. They thought it was their responsibility. So I think this is one of our goals, is to change the culture of medicine so that it's more friendly to people with addiction and that we can join the community in an effort that's really going to make a difference. Thank you.
I know we're running on a tight schedule, but do we have time for a few questions? All right, we've got a panel. We've heard some very powerful comments, so any questions from the audience? We've heard communities, we've heard about physicians, we've heard about Narcan. Young lady.
Hi, my name's Kima Taylor. I actually just have a question, I guess, for the panel. This is amazing work. But as we move towards the ACA and a lot more is covered by private insurers and private providers, are many of you working with some of the local insurance companies or others to integrate it within their systems?
Well, we've had the opportunity to work with Massachusetts Behavioral Health to train recovery support navigators. And whenever we go to train these navigators who are at the detox facilities, we talk about the naloxone and the overdose risk, in addition to the addiction science and motivational interviewing. So we've made some breakthroughs in some of the insurance carriers. And this is the state Medicaid behavioral health carve-out.
It's an important question.
So we have also, it's been interesting. I think there's some physician behaviors people will find unappealing, right? And there's a few of those. And then there's patients' behaviors that are unappealing as well. And I think one of the surprising things that we've been trying to tackle is the insurer behaviors that are incredibly unappealing. And so, I'll just give you an example. So one of the new one of the companies that's providing services through our exchange had only generic Subutex on its formulary. So when I was, trying to get approval for buprenorphine naloxone generic, buprenorphine naloxone film, or the new buprenorphine tablet for my intravenous opiate user, because I didn't want to give them generic buprenorphine alone, which we know has more abuse liability, I was denied. I explained it on the prior authorization. I then wrote again for another prior authorization request. I was denied again. And then when it goes to the third time, where you can do the phone call, you get put on hold. You spend a whole lot of time on hold. And at some point, I actually decided, I'm not going to be on hold anymore. I'm going to send a 40-page certified letter with all the supporting documents highlighting that the preferred formulation is buprenorphine naloxone. And in the cover letter, I said, I understand this is a new category of care that you're offering. It's very confusing. There's lots of different products. I will offer my services for free. I got a letter back saying your patient has been approved, but the formulary will remain the same. So we need to knock that away. There's no excuse for that kind of behavior, and it creates more costs on the system, and it's going to decrease our access of care if we don't get the insurers. And it's still your insurers, but then the insurers can have a different person that provides the PA, and the PAs change very quickly. So we're trying. It's an important thing to do.
Ms. Hale, do you have any comments on that question?
No.
All right. One more question, just one more question.
Thank you. Patrick Lynn from Quincy Police Department in Massachusetts. It's more of a comment for those that don't believe that naloxone in the hands of first responders save lives. I just give you our current statistics. We administered it 281 times and reversed 269. And those people represented family members, children, husbands, wives, and so forth. And we've taken that humanistic approach that these people belong to someone, and we do not put a cost on life. And we will be at it every day. It's no longer a program for us. It's a mindset within the department. So I'd just like to make that comment that it does work in the hands of first responders.
Very good.
Can I just comment that we all need champions? So, our state is very proud of what's happened in Quincy, and I think it came from the people themselves that were demanding that the police step to the plate, and our state has just adopted a policy that all first responders of any sort would have access to it. So I think this is the idea that sometimes practice drives policy, and hopefully we'll develop more research questions so that we can have evidence-based practices.
Very good. Just want to thank, we've heard from a community coalition, we've heard from two physicians in practice addressing the issue both from a substance abuse treatment perspective and from a perspective of overdose prevention. So I want to acknowledge the importance of this. This is the stage was set this morning by our August speakers. I want to note that my administrator, Pamela Hyde, is particularly interested in this issue. I'm joined by our chief, SAMHSA's chief medical officer, Dr. Ellie McCants, and several staff from SAMHSA, Bob Lubrin, Jin Hee Lee, and Jennifer Fan. Those are two of our pharmacists, because the issue is the pharmacists have to be actively involved in this. And I want to thank our panelists again for sharing their experiences and lessons learned, as well as their insights and recommendations. And we want to thank all of you for participating in this vital discussion. We will need to address a wide range of issues in order to make this dialogue in a summit useful. So I will be carrying my message back to my fellow center directors, Fran Harding from the Center for Substance Abuse Prevention, Paolo DeVecchio from the Center for Mental Health Services, and as well as Peter Delaney with our Center for Behavioral Health Statistics and Quality. The reason I point that out is that prevention and mental health, because we often forget about the mental health and the trauma experiences that people who present with some of these problems. And I think Ms. Hale pointed that out in terms of the kids, the histories and their experiences. It's not just growing up in a household where drugs are being used. It's the traumatic experience of growing up in a household that's being used. So together we will persevere in our efforts, and in doing so, we will save lives and improve the lives of our families, communities, and our nation. And I want to thank ONDCP for having this panel and this summit. Thank you very much.